I think we're going to go ahead and get started, and we're very full day. We're going to start off by just introducing ourselves. We're here to talk about SBIRT. First of all, let me just ask in the audience, how many of you know what SBIRT stands for? Okay, good. There's a mix of some people who do, some people who don't. We're going to be talking about that in our presentation today. Walking over here, I was just saying to Harmony, my name is Clay Graybeal. I'm a professor of social work here at the University of New England, and I also administer our SBIRT grant, which I'll talk a little bit more about in a minute. But walking over here, I was thinking about the presentations this morning and think about the changes in our approach to substance use and abuse and treatment over the course of my career. I actually it's a little shocking to me. I've been here at UNE for 30 years, and I started in social work about 7-8 years before that. And I remember I was working in a psychiatric hospital, and an individual was hospitalized for significant depression, and we were treating him for that. And it was my job to do the psychosocial assessment. And so I was going down through the list of questions that we asked, and one of those questions was about drinking. And he reported that he consumed about 1/5 of Johnny Walker per day. Now, we know now there could possibly be a correlation between that consumption of alcohol and his depression, right? But at the time, I asked him about his history. He had been in psychoanalysis for 10 years before being admitted. And I said, well, how did you talk about that in your therapy? And he said, it never came up. We don't do that anymore. Okay, Harmony, why don't you introduce yourself?
Hi, I'm Harmony Stratton. I'm a physician that trained in internal medicine and pediatrics and worked for several years, both in Worcester and in Rhode Island, doing primary care. And in primary care, we try and address the major health problems facing our populations, and currently for the populations where I've worked, that has been opioid use. And so I did a lot of medicated assisted therapy with Suboxone, and I'm a huge advocate for Suboxone therapy. It changes individuals' lives, it changes their families' lives, it changes their communities' lives. But you can't treat someone unless you know that they have a problem, and so that's where the concept of SBIRT comes in. And so I'm really glad to be up here to be presenting. I'm up in Maine because my husband's now a medical student at the University of New England. And so I'm very excited to be able to be part of coming up with solutions for one of the big problems facing Maine and the rest of the country. Thanks.
Thank you. So SBIRT stands for Screening, Brief Intervention, and Referral for Treatment. This is an evidence-based model that's shown to have very significant effects in helping to identify and intervene when substance use is a concern. And we're going to talk about different level of risk today. I really think that we think of this as really a harm reduction model because of its capacity to intervene, and sometimes in the briefest of settings. In addition to being a professor in the School of Social Work, I administer our SBIRT grant. One of the things that we're very proud of here at UNE is that in our educational grant, we have students from 11 different health professions here at the university involved and getting training, which is why we really think of it as an interprofessional effort. I'm glad that I'm co-presenting with a physician today because I think that's what it really looks like in the real world. But we also are involving dental hygiene students, PAs, PTs, OTs, nurses, and so on. The goal, which I'll talk about in just a second, is in more depth, but is we think that everybody, my subtitle for this presentation sometimes is everybody deserves a screening. Here are our learning objectives for today. We want to talk some about personal biases that we still have towards people with substance use disorders. Discuss the need for SBIRT to promote community and public health. We're going to review the screening tools. You also have a chance to practice a little bit. And describe and apply basic motivational interviewing skills for brief intervention. One of the side effects of teaching about motivational interviewing, we discover that our students and faculty all say, this works great with my kids and my husband too. So it's very, very nice, simple, straightforward ideas that you can implement. And then finally, the referral piece is to locate treatment and referral resources in the community. Okay, so think about, for a minute, a person with substance use disorder, and think about what images come to mind. Does everyone know who this is? Hugh Laurie, who played the role of in House, which is a television program. And House was really kind of both brilliant and a disaster, if you've ever seen the program. What other images perhaps come to mind? Right? Don't we tend to associate substance use, and particularly addiction, with severe dysfunction? Did you want to say anything?
Yeah, I think stories are very powerful, and I think we often relate when we have met someone and it changes our view. And I think many people, when you say, think of someone who struggles with heroin, you think about a homeless person who's, perhaps living on the street, which is why I picked this Google image to include here. And I think what we don't realize, unless we either have personal experience or know someone, is that many people who suffer from substance abuse issues, whether it's alcohol, whether it's heroin, whether it's prescription drug misuse, many of them you wouldn't be able to tell the difference between them and any member in this lecture. And I think for me in particular, I had one patient who had been on Suboxone for years and doing well, and she was getting a PhD in clinical childhood development. And to me, I would love to be able to have that be the first image that pops to my mind when I think of someone with substance use disorder. But even myself, sometimes when I think about, the problem, we think about, sort of extremes of the problem, and sometimes don't recognize our own personal biases. So.
It also brings to mind one of the things that people, many people who use substances become very skilled at covering it, right, and not looking any particular way. And so sometimes the person next to you could be under the influence and we don't necessarily know. Part of this entire model is really thinking about how do we create safety and respect and dignity for the person to be able to talk about that. So also, what words come to mind when you think about substance use, particularly substance abuse? We try and avoid that word now, abuse and also addiction, as much as possible, and focus much more on the concept of substance use disorders. But think about what words come to mind. Here are many of the things that do come up. Everything from, you can see down there, rock bottom and disease to recovery. Very important to think about what biases do you notice in yourself. And I think even those of us who've been working in the field a long time are exposed constantly to stereotypes in media, and they can still well up, no matter how much you think you've moved beyond it. I remember, I've often shared this example. It's not related to substance use, but a number of years ago I walked into a hardware store and I was looking for a very specific kind of thing, and there was a young woman at the counter, and I hate even admitting this, but I looked past her for the guy, and I thought, oh my God, that's still in there. And I asked her, and she knew exactly what I was talking about. In fact, she knew a lot more than I did, so that was a good lesson. Okay. So when we started out with the grant, we thought about we want to really state what's our philosophy and perspective on this, and this is something I wrote. Substance use disorder issues play a key role in the health of individuals and communities, and we believe that intervention can occur in even the briefest encounter with a sensitive, caring, and professional healthcare provider. One of the things we like to emphasize, you don't have to be an expert. What you have to be is have some knowledge and be caring to implement SBIRT. Okay, We're going to focus some of our attention today on alcohol and alcoholism because of the fact that it's still the most costly, most prevalent substance of concern out there. So here's just some background information. 38 million adults in the U.S. drink too much, but only 1 in 6 of them has talked to a health professional. The lower part of this slide, it sometimes comes as a big surprise that actually how different the level of risk is for men and for women. For men, binge drinking is 5 or more drinks. For women, 4 or more. For men, 15 or more drinks in a week. And for women, 7 or 8 or more per week. And that can come as quite a shock. One of the things we do with our students, we have them all fill out the audit for themselves, and a conversation I'll never forget, walking up to one of our medical students who's literally, she was just like, and I said, "What's going on?" And she said, "I had no idea the level of risk that I was at." And luckily she was in a very supportive, caring environment to be able to talk about it. So we're all keenly aware of this, the rise in opioid overdose deaths in America. 3 distinct waves, 1990s, 2010, and then the emergence of synthetic opioids, which you heard a lot about this morning. This is dramatic, and one of the things about it, of course, that's very different from the other substances is the rapidity and the fact how it raises the risk of death. Jump in anytime.
Yeah, I was going to say, I think one of the things, so when we talk about SBIRT, we talk a lot about alcohol because that's when the tool was designed for and implemented in, and we have less knowledge about how SBIRT works. But what we do know is that people who are using heroin today are basically 1 use away from death, and so there's very few other medical conditions that people are walking around on the verge of death, and as a physician, you really need to use whatever tool you have to try and prevent that. And so the idea of implementing a universal SBIRT in your practice is very important, because you can't save someone unless you know that they need to be saved. You can't treat someone unless you know that they need to be treated. And so with the rise of the synthetic presence of fentanyl in the heroin supply across the United States, people are at incredible risk of overdose, incredible risk of long-term disability from that overdose or death, and that permeates throughout their whole entire family and their community. And so, we need to ask more people and screen more people so that we can help more people, and that's kind of the sort of our message today.
So we're going to talk too, just a minute about ACEs. How many of you have heard the term ACEs? Yeah, great. And even though this will be perhaps repetitive for a couple of minutes, I find every time I look at this, it resonates again. So adverse childhood events, ACEs, come in this variety of categories: physical abuse, emotional abuse, sexual abuse, neglect of physical or emotional character, substance misuse in the home, mental illness in the home, divorce and separation, if the mother's treated violently, I think, or if anyone's treated violently, and a family member incarcerated. So why it's really important to understand these is, if you look at this this pyramid, is the cumulative effect of ACEs over the lifespan. Early on, one of the things we know about substances, for example, is the earlier the first time of use, the more likely and the greater the risk goes up, and the more risk of addiction. And also with ACEs, or very early disrupted neurodevelopment, that leads quite potentially to social, emotional, and cognitive impairments, often to the adoption of health risk behaviors. And long-term, what we know is that leads also to disease, potentially disability, and all kinds of social problems, and early death. One of the things we know, for example, I heard this stat again the other day, it's fascinating. In Washington, D.C., the difference in the zip code that you live in predicts a difference in lifespan of, I think it's 18 or 19 years. that if you live in the wrong zip code in Washington, D.C., you'll die 20 years on average earlier. The other thing is this direct correlation. So 4 or more of ACEs, you're twice as likely to smoke, 12 times more likely to have attempted suicide, 7 times more likely to be addicted to alcohol, and 10 times more likely to have used IV drugs. So it's really important to remember it's highly likely if you're dealing with someone, a teen or an adult who's under the influence and trying to work on that, they're dealing with a lot of other stuff too, most likely.
And I would add that if you treat that person who's dealing with all of those substance use issues, you're reducing the impact of those ACEs on their children, which has a huge health benefit for those children as they grow up to be healthier adults.
Right. You're interrupting that cycle. So we talk here about SBIRT for public health. Part of the goal of this is that every person will get screened somewhere. So not everybody gets to primary care, but if they get to a dental office, or if they happen to get a referral or see an OT or a massage therapist or whoever, someone will ask them the questions. And so first step is assessment of severity, and there are 3 levels that we think about. One is mild risk, and in that category, well, first of all, there's no risk at all. That's people who either don't use. And one of the things we do there is really encourage their healthy behavior. If they're at mild risk, it's brief education, just alerting them to the fact that their level of pattern may have long-term consequences. Moderate risk is where we really encourage brief intervention and brief treatment. There's a great video, which we don't have up here today, but of a doc in an emergency room. While he's suturing this guy's leg that he injured in an automobile accident, he's doing brief motivational interviewing, talking to the guy about how he ended up in this situation and what his level of motivation is to change. And then finally, high risk, brief education and then referral for treatment. One of the things we hear from many disciplines is, what if I find out there is a problem? What do I do then? And that's where it's really, really important to be familiar with the resources in your community, and also we'll have a slide later with some of those on it. Okay, so again, what is SBIRT? First, this screening step, we want to make sure that everybody has screening. We'll talk about a couple of screening tools in just a minute. And again, we'll focus. We've handed out a copy of the audit just for you to have a chance to see if you haven't before. But screening for all of these various areas, including prescription drugs, which obviously is an incredibly rapidly increasing area of concern. Brief intervention is, again, using motivational interviewing to raise awareness and referral for treatment. So what we want to talk about next is what some of the standard screening tools are. Do you want to talk about that? I'll get this out of your way.
So at the clinic that I worked at in Worcester, we decided that anytime somebody came for a physical, they were going to get their SBIRT, and so we had a packet, I think it was 5 different pages with different screening tools. And one of the problems is sometimes that can kind of, the patient's like, why are you asking all this? And but you sometimes discovered important things, and what I would say is one of the things is to figure out what's the most important thing that you want to screen for, how can you screen for it, what tools are available. And so we just put up a couple. So the CRAFT is a great screening questionnaire for teens and younger children. There's the audit, and then there's like a shortened audit that basically screens for at-risk alcohol use, and that can actually be incredibly effective because sometimes people aren't realizing that, oh, yeah, I guess I did miss a day of work because I was hungover, and oh, I guess maybe that is a problem. Maybe that's something I should think about. And basically the idea of all of these different screening tools is that they were developed for different reasons. Many of them were developed for research programs, but they've all been validated. So that means they've gone sort of through studies where people have looked at, do they actually get the information that you're interested in? Do they actually identify someone who is at risk? And are they and what target population should they be used for? So for instance, the craft is really geared towards, teens, and so you might not use it with a 30-year-old. Likewise, you might not use the audit that talks about employment with someone who's not working. Many of the questionnaires are quite long, but there are a couple that are short. The CAGE is the one that was very in when I was in medical school because it was 4 questions. The question for most prescription drugs or other substance uses is actually a very simple 1-question screening tool. In the past 12 months, have you used illicit drugs or prescription drugs for a reason other than their intended purpose? And so the screening tools vary from sort of long, more in-depth to short. And a lot of the shorter screening tools, the idea is that identifies a question of a problem, and then you would go on and maybe use one of the longer screening tools to flesh out the problem. One of the problems with implementing these is that they require a certain level of literacy, so a person has to be able to read or has to be able to have it read to them. These are translated into tons of languages online, and so if you live in an area that has a large population that speaks a certain language, you can often find them in that language. I worked at a clinic in Worcester that had 68 languages spoken. We had these translated into Vietnamese, Albanian, Russian, Haitian Creole, Spanish, Albanian, Vietnamese, Somali, Arabic. Though it was very interesting because then, when you got the answers, you would then have to look at your English version because I did not speak Somali or Arabic or Albanian and figure out which question they had answered yes to. So there are a lot of challenges to doing SBIRT, but there are challenges that can be readily overcome in our age of technology. I'll talk a little bit about brief intervention because one of the things is, what do I do when the person says yes? One of the most important things is to remain empathetic and open and realize that this may be the first time this person has realized that they're at risk for something. And so, to sort of use non-judgmental, open conversation with them. And so part of it is you get the screening tool and you calculate the score and you go, oh, this person is at moderate or high risk for an alcohol use disorder. And so you have to think to yourself, how am I going to approach that? And the first thing is to say to the person, I'm looking at, we had you do this screening, and I'm looking at it, and I'm concerned about what I'm seeing. You want to be motivational, so you want to be like, and you have a drinking problem, and we need to do something about it. You want to then sort of say, what are your thoughts on it? And get their thoughts. Many times people will say, well, I don't think I have a problem. And then, again, you want to be motivational, so you want to use this as an opportunity for them to think about their behavior. And so sort of just raising the awareness. And so some of it is saying, well, this is the part of the screening thing that is positive, and this is why I'm concerned. And sort of, then kind of throw it back to them to sort of find out if they're at a point where they, want to change that behavior or learn more about that behavior. The idea of brief intervention is that not everybody needs to be intervened on, but you'll notice the slide that we had about the risk groups, there actually wasn't a zero risk group up there because one of the concepts is that everybody is probably at risk for something. And so even people who are at very low risk, sometimes just sort of letting them know, hey, I'm glad that it looks like you are doing great. Keep up that behavior, or to let them know, you're a woman, and so the guidelines would say that, 7 drinks a week is, what's considered safe drinking behavior. If you ever are worried about your drinking, come back and talk with me. But the real targets for the intervention, so everybody should be screened, but not everybody needs a significant intervention. The real targets for the intervention are going to be those people who are at higher risk, so the moderate to high risk people. And the brief intervention can truly be brief. It can be, I'm concerned about your drinking. Studies have shown that when a physician or a nurse practitioner says to a patient, I'm concerned that you're smoking, that concern alone helps people quit smoking. And so these brief interventions can truly be brief, and it's mostly to sort of say, I'm concerned. and then to start that dialogue. Because your goal is to be able to provide information and for the patient to be able to, or your client to be able to bring that information back to you. People are going to be at various stages. Some people have known they've had a problem for years and have just been waiting for someone to help them, for someone to acknowledge that problem and for someone to say, I care, and let's work on this together to find a solution. Some patients don't think that their fifth of vodka they're drinking a day is a problem. They don't think that the 5 DUIs they have are a problem. They don't want to talk about it. They're not ready to change. And so for those patients, the key is to just sort of say, I'm concerned, and whenever you are ready, please come back and speak with me. And so that key is that rapport. If you can't sort of establish that trust, you're never going to be able to reach that patient or that client. And to let them know that the system is there for them is often all someone needs to do to reach out for that system. So how many people here have heard about motivational interviewing? Yeah. So SBIRT really depends on the ability to do motivational interviewing, because you screen people and then you want to motivate the people who are doing healthy behavior to continue their healthy behaviors, and you want to be able to guide people who are maybe not engaging in the healthiest behaviors to be able to embrace the idea of change. And so really motivational interview at the center is client or patient centered. So the idea is for that patient to be the change agent. It's their life. And people have behaviors for a whole bunch of reasons, and they change behaviors for a whole bunch of reasons, and they don't change behaviors for a whole bunch of reasons. And the idea behind motivational interviewing is to get them to sort of think about those reasons and to weigh them a little bit more. Most people, I would say in America, know that smoking is bad for your health, but many people in America still smoke. And so that seems, when you're like a 5-year-old, you're like, why does my mom smoke? It's bad for her and it makes the house smell bad. When you get a little bit older, you realize, wow, that person maybe smokes because their parents smoked and they have a stressful job and nicotine is very addictive. But you're still like, but why are they still smoking? There's they could go to their doctor and get Chantix. And so some of the idea behind motivational interviewing is to help the patient figure out what were the things that caused me to start smoking, what are the reasons I continue smoking, what are the reasons I would want to stop smoking, and how to use all of that information to enact the change that they want, not the change that you want. Because I think one of the other keys about motivational interviewing is that the patient is the expert on their life. They understand their daily life and the stressors and the happiness in their daily life that you'll never really be able to get in your limited interactions with them. And so to really respect where they're coming from and to respect their goals and to help them basically achieve their goals is sort of the key. And then motivational interviewing has got a lot of evidence-based medicine behind it. So the idea is that you want to sort of say to patients, well, here's what the current knowledge is to help them better enact the change that they want. So one of the keys to motivational interviewing, which is very hard to do, is this sort of concept of ORs. And the first thing is the open-ended questions. In a 30-minute dental appointment where your goal is to clean someone's teeth and make sure they don't have cavities, and we're asking you to screen and maybe talk to them about tobacco use, it's very hard to try and integrate that in. And we tell you, oh, use an open-ended question, and you're like, I've got stuff in their mouth. It's so much easier if they can just nod their head yes and no. It's the same in a primary care office. You think, oh, if I just ask a whole bunch of yes/no questions, it's going to be much quicker. Studies have actually shown that if you ask an open-ended question, you get much more information from the patient than if you ask a whole bunch of yes and no questions, because the patient, again, knows their story best. And so when you're doing yes or no questions, you're like throwing out a fishing line and hoping to get information back, whereas when you open things up, most people love to talk. That's one of my problems. Some people you end up having to pull teeth, not to go back to the dental questions, but I think that the more that you allow patients and clients to talk, the more you're going to be able to guide the interview. You also want to affirm things, and so patients are at different stages, and so you really want to congratulate them and affirm that they're at the stage that they need to be to take the next stage to move forward in reaching their goals. And so, if your patient says, well, I used to smoke a pack a day and I only smoke half a pack because I'm really trying to quit, you need to affirm that's great. In motivational interviewing, you want to do a lot of reflecting back. I understand that you tell me that you smoke because you find it relaxing. Reflecting back, summarizing. I understand, that you've quit smoking in the car. That's really great because your child rides with you. And then you can use those reflections to sort of throw back the ambivalence. If you're able to stop smoking in your car, why are you still smoking in the house? Those kinds of things.
Just throw in one thing. One of the things that I really love about this model is its strength-based kind of perspective. And one of the questions that we ask in this model is, what do you like about smoking? What do you like about drinking? What do you like about using heroin? It's a question that people, we've always assumed it's a problem, and yet, and there probably are problematic consequences, but that's one of the reasons why people do use substances. It alters their reality. Maybe it feels good. It helps them relax. It helps them be better at parties and meeting people and all of that stuff, And when that goes out of a person's life, they have to find things to replace it with. But I love that question, just what do you like about it? It's that non-judgmental, accepting approach.
It's actually my favorite question to ask my patients who smoke, because they usually get this really and then a few seconds later they open up about why they like to smoke, and the answers are, they vary from, it gives me 5 minutes away from my kids to, I just love the crackling sound of the burning embers as I'm dragging in. And it's a nice way to get a conversation going. It's also a good way. I usually use that question before I address the readiness ruler. The concept of the readiness ruler is people need to know where they are, and I think you'll have a little readiness ruler on the little cards that we handed out. If someone has never thought about their drinking as a problem, if someone has never actually told another human being that they use heroin, if someone is, a 2-pack a day smoker who's never thought about quitting, you're probably on your first attempt at brief interventions with them, not going to get them to stop that use. But what you are going to be able to do with them is to find out where on the readiness ruler they are. And you don't have to have an actual ruler, though some people find, I had a doctor who I shadowed who always used the exam paper, and he said, it's on a scale of 0 to 10, where are you in terms of wanting to stop smoking? And most people would do something around the 5, and then he'd be like, on a scale of 0 to 10, how excited would you be if you could quit smoking? And people often put it up higher, and then he would ask, on a scale of 0 to 10, he would be writing them, and then he would draw little lines, and that sort of movement and imagery for the patients was very helpful. But I think the concept of the readiness ruler is, your goal is, the ultimate goal is for the healthiest behavior you can get that patient to, or that client to engage in. And so if they're not ready to quit and they're down at the 0, you're not going to get them to quit. But maybe they actually are at a 10 for cutting back on their cigarette use, or maybe they're at a 10 for agreeing to come to a follow-up appointment with you. And so some of it is figuring out what they're ready for and meeting them there with the hopes that through constant sort of follow-up and constant expression of affirming their goals, you move them up on the readiness ruler to be able to accomplish their goal, which hopefully is to adopt healthier lifestyles. So, because just having people talk at you is not the best way to spend a morning right before lunch, we thought that we would do a little bit of practice. And so we've provided the audit. Again, it's an interesting thing to do. Our goal was for you to sort of pair up and to take a few moments to complete it yourself, and then basically to role play you being a provider of your choice, social worker, dentist, doctor, nurse, and to sort of use the audit and try some motivational interviewing to see like how that feels. You're welcome to fill out the audit honestly as it actually pertains to you, or you are welcome to invent a persona and fill the audit out as that person might. But I think it's useful to sort of look at the tools and use the tools, and then to sort of practice motivational interviewing and think about what do you enjoy, and then what do you not enjoy about I guess in the audit case it would be alcohol use.
So again, feel free to fill it out as yourself, or you can adopt a personality for this. And just one other thing about the readiness ruler, there's a tendency when, if somebody answers a 5, there's a tendency, especially when we first do this, to say, why aren't you at an 8 or a 10? And it's actually, we encourage you to do the opposite, go in the other direction, to say, a 5, that's great, how come not a 3 or 4? And that puts where they are in a positive place along the scale. Okay. So pair up, we'll give you maybe 5 minutes to do this, and we'll reverse. I know, it's weird.
It's funny, I find it interesting the ebb and flow of the
I'm probably.
Yeah, I mean, the clinical perspective, I would just, we can probably do like 5 minutes. So. But yeah, I can only give us like 5 minutes. Before 12:15, right?
Right.
I remember when I was in med school, the cage was the thing to do.
Yeah.
And now the cage is like considered. Now it's like the audit. I think it's the audit C, which is like the 10 is the 10 push audit, or something like that. It's like this is the one.
It's the one, yeah.
And I just I remember my clinic. I felt bad. Like it was like patients would come in for their annual physical, and they got given. It was the audit C. It was the PHQ-9. It was the GAD-7. It was the one question DAST. And then if you answered yes, it was the 10. But what would happen is most people's English and reading wasn't very good, and so it said if you answered yes, please do the next page. And most people would answer no and then try and answer, which is very hard to answer the questions about to further clarify your drug use if you weren't using drugs. So I'd come in, and even the PHQ-9, it's funny. I actually had to fill it out at my postpartum visit, and one of the questions is about sleep, and I was I circled that my sleep is terrible every day, which me and the OB laughed about because I had a 6-week-old. But I've had patients who've done it and then written in the margins, I don't sleep well because I'm a night shift worker. And you're like, yeah, that's the only question you answer yes to, so your score is a 3, which might indicate mild depression, or you're a shift worker. So,
An alternative explanation.
I had a Somali mother who her son was filling out. It was it's like the PSC, which is like a question for problematic behavior in childhood. It's like 21 questions, and basically the parent fills it out if you're under 12, and then the parent and the youth fill it out for 12 to 20. And the kid was filling it out, and the mother looked over and saw that he answered yes to some question, and she just started yelling at him in Somali. I said to the attorney, I was like, she's like, she doesn't want him to fail the test. She knows that he's not supposed to answer any of that the column is supposed to be all no's. But it was very interesting, and it actually raised my point. I said, many of these things have been validated, almost all of them have been validated in English and in English culture. she must have told him like he was the first of her. She had like 6 kids under 12 and teenagers, and he was the first teenager I saw.
So she knows it's like the vet, right? You said like failing the test.
Yeah, or that like, and again, the test, the papers are explained to them in Somali in a way that, I mean, I don't really know what the translators think, but probably said something around these tests are designed to let the doctor know if there's anything going on that she should be concerned about. So the culture, I believe, is one of, you know, you don't tell people that there are problems. You fix them in the family. So she viewed it as like an interesting.
I just thought of something that went right out of my head. Oh well.
Yeah, and it's interesting. There's a lot of research that actually suggests that SBIRT may not actually work with people with substance use, and part of it is that the referral to treatment pieces absent in many communities, and part of it is the screening is probably not done. It's probably not done universally, and it's probably not done very well without bias.
It's interesting. I have a colleague who developed PCOMS. It's a session rating scale that's used in behavioral care, and it actually is real-time feedback for the provider. And he said when he goes back to agencies, some agencies, this is fabulous, we're doing a good thing, and he goes back to others and says, no one will do it, and it's not working. And he says, okay, demonstrate to me how you introduce that to the patient. And you know, the ones who said, here's something you got to fill out, versus we find this feedback to be extremely helpful.
Well, what I found in my clinic was the paper got handed to the patient in the waiting room by the MA. They weren't given enough time to fill it out. I come in and my reaction is like, oh, they've got the papers in front of them. Like, I need to do my visit. And you have the option of I mean, and so then like your universalness becomes less universal because you're like, oh, I actually really want to know the PHQ line for that patient. So I'm going to give him the time to fill it out versus like, oh, that's my happy, healthy 22-year-old. I'm just going to kind of rush him through the forms, and so then you're going to get very different.
I just think maybe I'll have them switch. Okay, if you haven't done so already, switch your roles. Let's see, okay, we're giving that'll take us to Calvo 3, and then we can shift into.
I think we can just bring a little more perspective.
Can summarize and ask for questions.
Yeah, I think I actually really find the screening tools to be something that should be valuable, that in my clinical practice sometimes worked, and again, some of it was the piece of paper would get filled out, and then actually one of the things that used to drive me crazy is we went to this system where the piece of paper got filled out by the patient, and then the medical assistant took it and entered it into the computer, and then I was supposed to pull up the thing on the computer. I actually really wanted to look at the piece of paper, because I think you find, well, first of all, there's the things that are written in the margins, and you can also, I feel like sometimes you can tell the difference between someone who's like, you know, they circle 3 for I think about suicide every day, and then they cross it out and they circle 2. Versus, you know, to know that that was what was there. And so, like, I was always telling my medical assistants, oh, please take a piece of paper for me to look at. Which then annoyed them because they were like, they were supposed to enter it, so they wanted to take it out of the room to enter it while I was talking to the patient. You know?
Interesting. I hadn't thought about that.
I decided, no, I wasn't supposed to do this. I told my medical assistant, I'm going to just leave it, I will enter it in. It added like 5 minutes of work to me and was not how the medical flow was supposed to work.
But it gave you more valuable.
I found that the piece of paper was much more valuable.
Interesting. God, you know, I just wish we'd stop rushing practice, you know. If you had more time, right, you could relax, you could take the time to ask the questions you really want to ask.
And part of it is billing driven, right? So like if I bring you back 6 times, I get to charge you for 6 visits, which is more than if I address all of your problems in 1 visit. But like for want of a 30-minute visit, I'm going to do 4 15-minute visits and not actually accomplish 30 minutes of. And that's like my, you know, and then I think federally qualified health centers, they depend on grant money. So they get an SBIRT grant.
Right.
and we got a big Suboxone grant. I was the Suboxone person, and I was like, you cannot. I was like, I don't care what we do, but I can tell you the providers can't click. They can't. I won't click that box because it was one of these things. Like it was part of the grant was to prove that we're SBIRTing you, and I'm like, I SBIRT all of my MAT patients because I am like, we've already got. I was like,
doing it.
But I wasn't going to go through the 15 clicks to document it.
Right.
You know, but the health center needs that grant to stay afloat, and that grant requires, and it might be things like, can't we get like a medical student to come in?
Right, to come in
And like, I can have a piece of paper, and that was the big thing they were trying to move away from paper. But my point was like, but if we have a piece of paper, I don't have to click the box. You could have like somebody come in and like click the boxes for me.
Oh my God. Let's see. How are they doing? It's like, I think I'll go ahead because we're. Okay. Just take a couple of seconds to wrap that up. So our time is flying by pretty quickly, but you just want to check in. What was that like? Any observations, comments you'd like to share about anything that worked or didn't work? Did you run up against any obstacles? Did you make a discovery? Anything? Yes.
Looking at yourself and you're being asked these sort of questions and you're trying to be honest, and if we as like most of us are professionals here, like, you know, feel awkward doing this, imagine what it's like for somebody who actually has a problem.
Yeah, one interesting thing though is that one survey showed that 93% of patients in a primary care setting expect to be asked something about their substance use or smoking, which is really interesting, isn't it? But there is that discomfort question, and so part of our job is to really help people be comfortable. Yeah. Here comes the microphone.
As a clinician who's been using the audit for many years and a former DEEP provider, that's a drug and alcohol prevention program for the people who get OUIs, I love this particular assessment screening tool because, first of all, it's not a closed in like the MAST. It's not a yes and no.
Right.
It's very easy to not tell the absolute truth on the MAST or the DAST, but this one is how many and when and in the past, so it's great. I love this. I use it all the time. But I also wanted people to know that it's not a simple test. The interpretation of this test is a 37-page booklet. So if you want, it's not only the number, like in this case, the number 6, that's low. That's not a problem. But where is that number showing up? That's the big, the thing you need to look at as well. So that's my 2 cents.
Thank you. Yes, back there.
Thank you. Loud. I was thinking about the initial, like the concepts of SBIRT and having it be like a short thing that can happen. And when I was thinking about the different substances and the different screeners that are specific to substances, or do you guys have any experience on screening tools that can be used at like a higher level and then using like the audit as a drill down? Or, because as I'm thinking about clinicians who are individual practitioners, in the world of behavioral health, they're the sole team, right? And so they don't really have kind of the support network that they might have in a primary care practice, for example, to pull together.
Yeah, so I think, one of the dogmas in medicine is that you shouldn't screen for something that you can't do something with the screening results. One of the nice things that the concept behind SBIRT is that you can do something, and I think, but trying to figure out what the correct screening tool is. And so, for instance, the MAST and the DAST was mentioned, and so the DAST I think is a 10 or 12 questions that sort of details substance use. But the first question is, in the past 12 months, have you misused a substance? And if you answer no, you're done. And so that's a great initial screening tool. If the answer is yes, you're then supposed to give them the full 10 or 11 follow-up questions, which goes into what substances and how often. And again, the concept behind brief interventions is the brief intervention is very brief. It is sort of, this is why I'm concerned. And then I think we have a slide coming up, which is sort of the concept of referral to treatment. So sometimes you can just self-refer. If you're a drug and alcohol counselor, you can refer to you say, oh, I've screened you because you came in for depression, and I'm concerned about your substance use, and so let's talk about my concerns and figure out where we're going to go from here, and refer to yourself and have them come back and see you. If you're, I provide Suboxone, so if one of my patients screened positive for opioid use disorder, I was like, okay, let's set you up for a Suboxone follow-up. And again, there are tons of different screening tools. I mean, most the current recommendations is that you probably want to screen patients for at-risk alcohol and substance use. And so the audit, I love the audit for those very same reasons. It asks more open-ended question than the cage, which is like yes or no.
There's also another, we didn't hand out that version, but this version of the audit doesn't have, there's like 5 other questions at the top that ask about substance use, smoking, do you wear a seatbelt, kind of those generic questions that covers a lot of ground quickly. Yes?
In a non-clinical position, but the approach being non-judgmental, and when you say I'm concerned, to me sometimes that feels like that's putting the person in a defensive position. So I'm wondering if people have had experience using other terms, what might be used, like I'm interested or I noticed this.
One of the things I sometimes will do is say, a lot of people who use substances at the level that you're using encounter many problems. What do you think about that? But I also will say, what Harmony said is that's a powerful statement coming from also, it's not coming out of nowhere. Once you've completed that and you have this information, for a physician to say, I'm really concerned, I think a lot of people feel that not so much a judgment as I get it, or, you know what I mean? It can be very powerful.
But I would agree, the sort of words we use are very powerful and have different meanings to different people, and sometimes you can say something that you've said to 27 other patients and it's been a swimming success, and then you use the word concern for your person who just said that they basically binge drink 3 days a week, and they're like, well, I'm not concerned, and it shuts the conversation down, and so then you're like, oh. And so part of it is, as a primary care doctor, you get to know your patients a little bit, and so but I have had the experience as a resident of, I had a woman who was binge drinking. She was doing, she was doing Sex in the City. She did 3 nights a week drinking with her friends, and they were drinking 4 or 5 margaritas at the bar, and she didn't think it was a problem. And I said, well, I'm concerned. And she said just that, well, I'm not. And that was it. And so that was not the right thing to say to her. And I think, I'm trying to think the other things. So I often, it's funny, I actually find the PHQ-9, which is a depression screening thing, the screening tool that I used a lot in primary care, and then I would see something very concerning. And so I would often, and I was just saying to Clay, I hated the clinic I worked at, the medical assistants were supposed to take the paper and then enter it into the computer, and I was always like, keep the pieces of paper with me, because I would show them the paper and I would say, tell me more about how you answered question 2. And so I didn't have to say I'm concerned, but that was because I was concerned, because like question 2, they said that they were like never sleeping, or that they had no energy or something like that. And so sometimes actually using the piece of paper and saying, tell me more about this, is how I would actually open the conversation.
Question back here.
Yep, hi. I was just wondering how accurate you find these screening tools, and I ask that from the perspective that sometimes people with substance use disorders aren't always honest. So I was just kind of curious as to how accurate you found the tools.
So they've been validated, which suggests that they do a good job screening. So they can be valid and not accurate. And I think part of it kind of goes to the readiness concept. If someone's not ready, they're not going to fill it out in a way that would trigger the conversation, and that just is what it is. I think, but they have been, again, I think a lot of times people are waiting to be asked the question, and so I think they have been shown in studies to actually capture, I think, a clinically significant amount, and they're sensitive but not necessarily specific, and so you do catch people who are at risk. You might not catch everybody, but you catch a lot, and you might catch people who screen positive who in further discussion aren't,
Yes, over there.
Just a quick follow-up on your patient who was not concerned. When I have a client who says that, I like to ask them, well, what would need to happen for you to become concerned?
Right.
And let them define the line in the sand, which, eventually could lead to a conversation down the road when they say, that thing that I said, if I did this was a problem, I did it. So now I'm back to talk about it.
That's a great follow-up, and it helps, again, it's individualized treatment. You're really calibrating it to that person. I'm realizing we're just about out of time. So we wanted to share, here are some resources that, there is a 211 number. If you don't know that, you can call and find out about resources in your community. Also, U.S. government, there's a mental health substance abuse site. You just Google that and go on, and they'll provide resources in areas. And then the alliancemaine.org. And let's see, which one is this one?
It's a kind of a complicated thing, but it's basically it's like the CPPC Maine. They actually have like a York County PDF of all of the sort of substance use provider resources for York County and Southern Maine.
Well, thank you all very much for coming.